Here. I'm on behalf of our IAP President, Dr. Sindhu, is here to welcome you all to this yet another edition of IAP PG Club. So I welcome at the outset the very senior members who are present here, Professor Srinivasan and Dr. Purushothaman sir here. It is here. And we have our scientific coordinator, Dr. Anandakeshavan, and many others. So I welcome especially all these members and also the IAP state coordinator, my own classmate, Dr. Mohandas, then zonal coordinator, Dr. Aslam, and we have the faculty here. Today is Dr. Babu Francis. Dr. Babu Francis. And today we are going to have the presentation by Dr. Nilmal Raj, and the mentor is Dr. Shruti. Both are from Malabar Medical College. So I would like to welcome you one and all yet again. And now, Dr. Mohandas, next what is the procedure?
Okay, so I would like to congratulate Dr. Aslam, who is the zonal coordinator, for arranging today's session, and also Dr. Shruti, who is the mentor of today's program, and Dr. Nirmal Raj, who is going to present case, and Dr. Babu Francis is well known to all in this audience. He retired from Government Medical College, Calicut, as professor in pediatrics. As he already mentioned, he studied pediatrics under Srinivasan sir, and is a very good academician and a very good clinician. And so I think all of you will enjoy today's discussion. And I'm also very happy to see many of our senior teachers, Srinivasan sir, Purushothaman sir, Sushma madam. I would like to invite Anandakeshavan sir, who is the scientific convener of our PG club, to say a few words.
Very good evening, respected Chairperson Dr. Abdul Latif, in the absence of Dr. Sindhu, scientific IEP coordinator Dr. Mohandas Naya, my close friend Babu sir, Dr. Purushothaman sir, Sushma madam, and Dr. Srinivasan sir, and all my dear colleagues and members of IEP family. So very happy to see that program is going very smoothly, regularly, without any interruption, and well advanced. Mohandas is doing a very wonderful work. He is allotting the topic very early and also doing it very systematically. As I mentioned last week, means all the zonal coordinator. Today it is Aslam and last. So all zonal coordinator are doing a very wonderful work. Without wasting much time, I will start the program. I wish the program all success. Jai Hind, Jai IAP. Over to Mohandas.
Mute on.
Mohandas mute on. Mohandas will unmute you.
Dr. Shruti, you want to say a few words? Shruti is the mentor of today's.
Yes.
Shruti can change her name.
Aims transmitting live.
Sorry. So am I audible?
Yes, yes.
Yes, you're audible.
Yes, sir. So sorry for not changing the name because it was the name which I kept for some other.
It's okay. It's okay.
Yeah. So thank you. So thank you for this opportunity.
Yes, continue.
Sir.
You can continue.
Okay.
Yes, sir. So thank you for this opportunity. So we've tried our best to present this case in the best possible way. So we are hoping to, yeah, we're looking forward to, have a awesome discussion in this session. So yes.
Okay. So, Babu sir, you can take over.
Another student also joined, Dr. V.K. Parvati madam.
Parvati madam,
Okay.
please
Welcome, madam.
My appeal to all the senior faculty is to contribute to this discussion, this being a neurology case. And I invite Dr. Nirmal to start the presentation. Without losing much time, we'll go straight to the presentation.
Babu
we
sir,
are lucky
first
to
I will
have-
mute all and you can unmute. Okay.
Yes.
നിർമ്മൽ അൺമ്യൂട്ട് ചെയ്തിട്ടില്ലെന്ന് തോന്നുന്നു. നിർമ്മൽ അൺമ്യൂട്ട് ചെയ്ത് സ്റ്റാർട്ട് ചെയ്യോ?
Nirmal unmute ചെയ്യണം.
Am I audible, sir?
You're audible, Nirmal. You're audible.
Good evening, everyone. Today I'm going to present a case. Patient name is X, male child. Age is 10 months, 16 days. Second born of a non-consanguineous parentage. Informant is mother, and its reliability is good. Hailing from Narikuni, Calicut. Chief complaint is delayed attainment of milestone appropriate to age and floppiness. Since the problem begins from the antenatal period, I would like to start from the birth history. Antenatal history: maternal age at conception is 38 years. It's a non-consanguineous parentage. No history of use of any other drugs other than iron and folic acid. No fever associated with rash. No history of radiation exposure. There is history of decreased fetal movement present and also a history of polyhydramnios. Antenatal scans were otherwise normal. There is no history of gestational diabetes mellitus, hypertension, hypothyroidism in mother. Coming to natal history, it's early term 37 weaker, born via emergency LSCS. Indication is abnormal Doppler and non-reactive.
Nirmal, shall we stop at the antenatal stage?
Yes.
The different points. Okay.
Yes.
So you can tell us what are the points in antenatal history in this context you will seek specifically.
Specifically, there's a positive history of decreased fetal movement and also a history of polyhydramnios in the antenatal period.
What do you think the possible causes for decreased fetal movements?
Decreased fetal movements can be due to reduced activity or hypotonia in utero.
Okay, what are the conditions you will consider? Like if it is you mean a neurological issue causing decreased fetal movements?
Decreased fetal movements like.
Okay, so okay, what are the conditions you will consider in this context?
Can be congenital myopathy.
Congenital myopathy.
Congenital muscular dystrophies. Arthrogryposis. It can all cause reduced fetal movements and also polyhydramnios. Congenital myotonic dystrophy can also.
Myotonic dystrophy. Okay. Okay, carry on. What else could be the reason for decreased
Is the age
movements?
of mother important? Is age of the mother important?
It's a maternal age at conception is 38 years.
Is it important?
Yes, it is. It is important. It can. It is a risk factor for chromosomal anomalies like Downs, etc.
So again,
Okay.
decreased decreased fetal movements can be attributed to that also. Is it possible?
Yes, it is possible. Like chromosomal anomalies like Downs, Prader-Willi syndrome, all have hypotonia.
Okay.
I think it is better to mention first trimester, second trimester, third trimester like that. Okay, that may be more attractive also. So you can avoid missing some points like history of UTI. It is a case of neurological case. So history of UTI is important. and any delay in consumption because whether they are taking any drugs or any after long infertility treatment, everything you have to mention here because it is a neurology. I think it's a neurology case you have to mention like that. First trimester, second trimester, third trimester. First trimester more. You mentioned about the drugs. What are drugs? We are asking about the drugs
No.
here. Drugs.
History of any intake of any. Hello.
Some of the drugs producing neurological problem.
Any history of teratogenic drug intake or
Okay, you can continue.
Yes.
Continue.
ക്ലാസ് എല്ലാവരും ഒന്നുകൂടി മ്യൂട്ട് ചെയ്യുവോ എന്നിട്ട് വീണ്ടും അൺമ്യൂട്ട് ചെയ്യൂ.
Nirmal, what is the reason for polyhydramnios?
Polyhydramnios, it can be due to the weakness of pharyngeal muscles, so that the swallowing process is not properly taking place. It can lead to polyhydramnios. Hello, sir.
Situations you get polyhydramnios.
Sir, the swallowing muscles have got weakness, which causes polyhydramnios. Difficulty in swallowing, which can attribute to polyhydramnios.
Okay, but are the other other situations where you may get polyhydramnios not related to this? Where else the swallowing is not possible? Esophageal atresia.
Esophageal atresia.
Okay, and similar conditions can cause polyhydramnios. Okay, you carry on. Any more things? Wanda, say anything? Anything else?
As Nirmal has mentioned, that Prader-Willi syndrome can also be associated with advanced maternal age. I don't think so. Usually the aneuploidies like Down syndrome is associated with advanced maternal age, Prader-Willi.
So, okay. Sir, actually, that reduced fetal movements.
Yes, you have to suspect conditions which can cause reduced fetal movements like Prader-Willi,
yes,
congenital myotonic dystrophy, congenital myopathies, all such things, but not associated with advanced maternal age.
Okay, sir. Okay.
What was the reason for this 38-year at the time of delivery conception? Is it was there any history of a previous abortions or anything?
No, sir. There is no history of previous abortion or any infertility.
What is the time of marriage?
Marriage is around 26 years is married.
So infertility was the
no history of infertility was there.
Was he on in treatment for this thing from 26 to 30?
No. This is the second born. First child is around 11 years old.
There was no loss in period because there is an importance is there can be a possibility of a myotonic dystrophy. Myotonic dystrophy is an entity which has got multiple the involvement, muscle, heart, intestine, endocrinological, and can be infertility situations also. But in the paternal side, some problem with the sperm. Paternal side infertility.
Can be associated infertility also.
But for the males, not for the females.
Okay.
But in myotonic dystrophy can be inherited from the paternal side also. So is the father having some fertility problem which is responsible for the conception? That's the relevance of this thing. And the other way around, Down syndrome definitely is related. The other thing is esophageal obstruction can lead to hydramnios, but esophageal obstruction can be a part of a malformation.
Malformation.
So multiple ways of considering these two contexts. Decreased movement on one side, and the other thing is there are two hard findings. What is the other things? Hydramnios. That's on the mute ചെയ്യാൻ പറ്റും എല്ലാരെയും കൂടി മ്യൂട്ട് ചെയ്തിട്ട് റീകൺസിഡർ ആരൊക്കെയോ കേൾക്കാതെ വെറുതെ ഓൺ ചെയ്ത് വെച്ചിരിക്കുക. എന്തിനാണ് ഇങ്ങനത്തെ ആൾക്കാർ വരുന്ന കാര്യം എന്നാണ് എനിക്ക് മനസ്സിലാവാത്തത്.
All others are muted. Please continue.
Sir, can I continue?
Normal, continue.
Okay. Natal history, early term 37 weaker, born via emergency LSCS. Indication was abnormal Doppler and non-reactive NST. Birth weight was 2.265 kg. Baby cried soon after birth, but the cry was a weak cry.
Normal, 1 point. What say lie of the baby, mode of delivery? Is it a vertex presentation?
It is not breech, it's cephalic itself, sir.
Okay. What is its significance? Suppose it is a breech.
Okay, in the early stage, hypotonia or the reduced fetal movements and polyhydramnios can cause malpresentation, sir. But in this baby, it is cephalic itself.
You mean due to polyhydramnios or the movement is reduced? That's why it is. That's what your explanation.
Polyhydramnios and also the reduced due to hypotonia also malpresentation can happen.
Rather, I think the fetal movements in utero fetal movements have something to do with the length of the umbilical cord. I think others can verify this. I think the length of the umbilical cord is less, so the mobility of the baby is restricted. That is again another explanation. Pushu sir, any comment on this?
I'm first time hearing that. The point in this baby is surviving up to 10 months, having developmental delay. We don't know whether it is in gross motor only or in the other field also affected. In that situation, you are getting a case of antenatal period itself showing abnormality, hydramnios and weak movements. So there you need to consider what's the type of pathology responsible for this thing. If it's a progressive type of pathology like SMA, it must be serotype. Okay. 0, 1, 2. So it's a combination of starting in utero and alive at 10 months. So SMA usually with this seriousness, type 0, antenatal period onset, it will be having the worst of the problems in newborn period, and the chance of surviving up to 10 months is a bit unlikely. So at this stage itself, should we consider that or a non-proxic condition like myopathies? So at this stage itself, there should be an analysis in mind. Okay.
That's a good consideration. What you mentioned is quite true. And the final thing is not yet resolved in this child. It's not a straightforward case. So they are right from the very onset, there is confusion. Okay, Normal, you can continue.
Okay. So neonatal history, baby was admitted in NICU on day 1 of life in view of chest syndrome and was on oxygen support via hood for 3 days and had NICU stay for 10 days and was on IV antibiotics. Child was on tube feed on day 1 of life, which can be attributed to difficulty in sucking and swallowing. Baby was discharged on day 10 of life on palliative feeding. At the time of discharge, child had decreased spontaneous movement seen in all 4 limbs. And there is no history of neonatal seizures or...
one point here.
Okay.
So what we were anticipating was a problem with the power, whether it is in the muscle or minor junction or these are all under consideration. At this stage, one point you mentioned, the indrawing part. That is a point which need to be considered, because for a distress or respiratory cardiovascular problem to cause dyspnea where worker breathing and indrawing is there, that's a point, because that will not be there in a case where there is muscle is weak. So in this case, muscle is not that weak at the time. That is a clue. You said indrawing. That is important. Okay, go ahead.
Okay.
There is another point in this. You may mistake an intercostal weakness for a respiratory distress, because prominent diaphragmatic movements can be misconstrued as respiratory distress. Okay, so there can be events in the transitional phase in the newborn period compounded with the intercostal weakness, which may be manifesting as prominent retractions. So it need not be respiratory or cardiorespiratory. It can still be a neuromuscular cause, which is misconstrued as a respiratory distress. So we have to.
That's a good point. I was considering one way, and Babu was pointing out another useful point. In that case, that is a diagnostic clue. It can be, it's an argument for SMA type. Diaphragm, spared and intercostal involved. So it looks something like indrawing. So that will occur only in one of the situations, SMA, not on the other situations.
Nirmal, why do you think there is a weak cry? What could be the reason?
Weak cry due to hypotonia, sir. This muscular weakness and
Hypotonia will not cause weak cry. Which muscle weakness? Mainly indicates respiratory muscle weakness.
okay. Respiratory muscle weakness.
The cry, what are important in the cry is the intensity of the cry and the change in the other cry pattern. Here, intensity is important. Intensity indicates a tidal volume. So any situation where the tidal volume for expiratory, it's less, means voice will be small. Okay, in this case, respiratory weakness is responsible for this thing. Well, that's an indicator that there is some weakness.
Another point in this juncture is in the newborn period where there is a suspected peripheral cause, which can lead to a combination of central plus peripheral. We had previously a child. So any neuromuscular cause can cause secondary or postnatal asphyxia by like either not able to maintain airway, or the resuscitation process was not proper because it was not considered then. So probably child can develop secondary asphyxia. So finally you will end up with a child with a HIE plus a peripheral neuromuscular problem. So it can occur. So we have to consider the combination of these, one cause for central plus peripheral. When you evaluate later, one etiology is postnatal asphyxial brain injury. Okay, Nirmal, continue.
Okay. There is no history of neonatal seizure or hypoglycemia, no history of DDH or clubfoot. Brain scans and other blood investigation were done and was normal. Child was started on oral vitamin supplement and advised physiotherapy and was on regular follow-up. After discharge, child had sucking difficulty and was on palliative feeds, which gradually improved. At 1 month of age, child was sucking along with the palliative feeds. However, child was not able to put completely on direct.
In this context, you need to mention about the limb movement and the activity. Because there are situations where predominantly swallowing problem will be there. There are situations where overall movement is diminished and swallowing problem is there. There are situations where the spastic situation where swallowing problem will be there. Just like Babu said, predominantly a central cause will lead to different patterns of the situation, sensorium and swallowing and the limb movement and the tone. Okay, because there are situations like Prader-Willi, you said, few of the situations initially there will be swallowing problem and floppiness leading on to later other problems. So in a situation, there are other situations like leak syndrome, dysautonomia. Those are situations where predominantly swallowing will be affected. A little bit of affection of the limb movement. So you need to mention about the adequacy or the inadequacy of the spontaneous limb movements, upper limb, lower limb. Okay.
Initially, there was no spontaneous movement was not there, and later it progressed. And coming to the histories. Am I audible, sir?
Normal, one more point is in the newborn period, you have gone up to the point of discharge. So one thing about the movements, as sir said, the limb movement, motor component, how bad it was, whether it was improving with the time, and approximately what was the power, how the baby was moving the limbs, and then whether the higher functions like the baby's attentiveness, its like cry, and its consolability and adaptiveness. So such higher functions, whether it was there. So that subtle details you have to go. So what were the neurological functioning of the baby in the newborn period? And so I think some more details are needed in that order.
Okay, okay, sir.
Okay.
Can I continue, sir?
You continue.
Parents also noticed a reduced movement of both upper and lower limbs, but child was aware of the surroundings and interacting with mother. There were no behavioral disturbances. Parents also noticed that the neck control not attaining. Child can now only momentarily hold the neck. Now child movements have considerably improved and moving both hands and limbs. Cry is still weak, tolerating oral feeds well and with good weight gain. Child is now able to lift the arm above shoulders. Child is able to reach out and hold objects. Child is able to lift the head from the bed for few seconds. Able to turn in bed, but not able to sit from supine position. And there is no history of squint, drooling of saliva, collection of food in cheek, deviation of angle of mouth, nasal regurgitation of feeds. And there is no history of abnormal movements, fasciculation, constipation, excessive setting or flushing of skin. No history of contractures, pressure sores or ulcers. No history of recurrent vomiting, and no history of recurrent respiratory tract infections. Hello, sir. Can I continue?
Here it looks you have jumped from the newborn period up to 10 months. There was a lack of continuity in the story. It was not mentioned as a story. So don't jump to the conclusions and the possibilities, and you are bringing out a list of no's. Rather than that, you go forward with the case free to analyze. Okay.
Okay.
So that is not coming here. From the newborn period, present status you are coming. Okay. So we are interested of how it was actually the pattern of the development, especially you didn't tell about the feeding. So when did they start the normal feeding? How long the baby was fed with Gokarnam feed or water? And the other pattern, that is so important. The swallowing problem was the major problem in the newborn period. And now you are jumping to the other thing. So in between, lot of a gap is there. Babu, you take over.
Hello, sir.
Babu പോയോ ദാസേ കാണുന്നില്ല ഓഫ്ലൈൻ ആണോ ബാബു
ഓഫ്ലൈൻ ആണ്
Okay, what was the situation? Our feeding and all?
Sir, at 1 month of a child was sucking along with the palate feeds. Child was not able to put completely on breastfeeding because sucking was an issue there. And they had started at 6 months of age. They have started with semi-solid foods, and it is tolerating well. Not completely.
The content of the food. We are more interested about when you talk about the feeding. You are interested about the content one, the method of feeding, Okay, here more importance is to the method of feeding. And about the contents, what was the content? Is it liquid or semi-solid or a solid? So what is the pattern of the feeding? Okay, that's more important.
Okay.
How long they use the Gogurnam? 6 months.
6 months, sir, along with direct breastfeeding.
Semi-solids when they started?
6 months. After 6 months, they have started with semi-solid.
Okay. After some time, you'll be coming to the this thing. Okay. Go ahead with the development. That's any in the
Babu sir is back.
ഇടയിൽ വൈഫൈ
Babu
പോയി
sir
ഞാൻ
is back.
കുറച്ച് വിട്ടുപോയി കേട്ടോ വൈഫൈ പോയി ആ
Now back. Yes.
കുഴപ്പമില്ല ഓക്കെ ക്യാരി ഓൺ
ഞങ്ങൾ അതിന്റെ അടുക്ക ഡെവലപ്മെന്റ് ഒരു സ്കിപ്പിംഗ് ആയിട്ട് ജമ്പിങ് ഫ്രം ദ ന്യൂ ബോൺ പീരീഡ് അപ് ടു 10 months പോയി പറഞ്ഞായിരുന്നു ബാബു
കണ്ടിന്യൂ ചെയ്തോ നിർമ്മൽ കണ്ടിന്യൂ
because Nirmal, what are important is you need to keep a wider possibility at this stage. It can be a central hypotonia situation, floppy, weak and floppy, strong situation. Okay. In this situation, there can be associated problems like cardiac involvement and all. So what you need to tell is there any clue regarding those involvement also? So those are missing. So during this 2 months period up to 10 months, so we are interested about the other aspects also. So which all things are affected? Is it a central or a peripheral? In the peripheral, apart from the usual weakness part, is there any recurrent pneumonia due to aspiration? Is there any suggestion of the congestive cardiac failure situation? What about the constipation? So many points are relevant from these 2 months to 10 months. That's right. Okay.
So there is no history of recurrent infection, no history of constipation, no history of nasal regurgitation of fluids. Sir, can I continue?
Continue.
On the development history part, gross motor, neck holding not attained yet. Only momentarily he's holding neck. That's it compounds for about 4 weeks development only. No other gross motor development has occurred. On the fine motor part, a child is reaching for object. There is bidextrous reach at 8 months and unidextrous at 10 months. The fine motor development age is about 6 months. And social and
Nirmal, when do you expect the child to reach out for objects? Bidextrous approach. Bidextrous approach. When do you expect the normal child to do?
4 months, sir. 4 months, sir.
Okay, 4 months.
This baby, it attained at 8 months and in unidextrous by 10 months only.
Okay.
Social and adaptive part, social smile at 3 months. He recognized mother at 4 months and stranger anxiety at 6 months. Language, now the baby only doing monosyllables like polyphonic vowels like only that sound is making. Bisyllabus not attained yet.
No, it is very important to seek signs for central involvement. So whether we can is it a central or a peripheral or a combined issue? So it is important to look carefully into the developmental aspects because anyway it appears to be a differential sort of developmental delay. Okay, so are you considering the social and adaptive milestones perfectly normal for this child?
Not perfectly, sir, but comparing with gross, the social, this cognitive, social and language development.
So I am concerned about the cognitive function of the baby. How can you assess at this age? Like you said, stranger anxiety at 6 months. Okay, what else? What are the other things you expect around 6 to 7 months baby? To assess the higher functioning of the baby. One is, of course, stranger anxiety. What else?
Interaction with mother and other at 9 months, it waves data and all. And they will play.
But this baby is 11 months now. Is it 11 months?
It's 10 months, sir. 10 months. Taking history, it was 10 months.
Okay,
16
so at 10 months, what are the social and milestones we expect? Psychosocial milestones.
10 months or 9 months, you can wave bye, and it can play simple ball games and all.
When do you expect a baby to enjoy the mirror image?
Sir, pardon, sir.
Mirror, enjoy the mirror, its own image in the mirror. At what age? I think this baby had to go all out to see whether these psychosocial milestones are normal, or is it purely a motor issue we are dealing with?
More of a motor issue, sir.
That is agreed. What are the other psychosocial milestones around this age? നമ്മൾ സാധാരണ കുട്ടികളിൽ കളിക്കുന്നു, നമ്മളിങ്ങനെ തപ്പുകൊട്ടൊക്കെ ചെയ്യില്ലേ, കൈമുട്ടുക, പീക്കപ്പ്, അങ്ങനെ ഒളിച്ചേ കണ്ടേ കളിക്കുക.
ഇല്ല, അതൊന്നും ഇല്ല, സർ.
അതോ ചോദിച്ചേ, those things you have to ask.
Peekaboo and all those things are not.
That's exactly, that's what. ഇപ്പൊ നമ്മള് ചില സാധനം റിലീസ് ചെയ്യുക, കയ്യിൽ ചോദിച്ചാൽ തരിക.
No, sir. Those milestones were not present.
Okay.
Because up to 6 months, this baby had a normal social and adaptive development. So
Yes.
you have to verify that whether child continued to attain milestones in that respect. It's highly likely that the social development is normal.
അത് കുറച്ചും കൂടി, I think you need to go into more details to that aspect, because this child has got a motor disability. So to elicit psychosocial development is a task. So you have to carefully go into those details. Okay.
Babu sir പറഞ്ഞ point ആണ് നിർമ്മൽ. It's very, very important because developmental assessment is the most important decisive point here, because there are many ways it is important. There are situations where it's a purely floppy weakness, motor unit disorder, centrally perfect. Classical example is a SMA situation. The next one, early onset SMA with a birth asphyxia. Then it becomes one plus the other also. So that situation, there can be a dominant motor delay with some problem in the higher function situation. There is another situation, few of the muscle dystrophies which has got an early onset, congenital muscular dystrophy. There it can be peripheral plus central due to another reason. So multiple ways in which this developmental pattern can be the classical one. What we need to know is it a pure motor with or without fine motor? This is considered together. Okay, social part, you need to spend more time in this context, because that will be modified, as Babu sir said. Assessment is too difficult. A little more effort you need to take to say assessment, the social language is there. So as Sada sir said, most likely this may be normal. If you think it is still abnormal, your diagnosis goes a little away from this thing. SMA with a central injury or another disorder which will be affecting both. Okay, so that part is very, very important in this case. Go ahead.
Vision and hearing also is normal. Diet history, totally calorie intake is 1020 kilocalorie and expected is 800. There is no deficit, he is well nourished. Immunization history, child is not immunized up to age according to national immunization schedule. Last vaccination at 9 months, PCV booster was pending, no adverse event.
Normal, just one point, you said that the nourishment is good. So indirectly you are trying to say that there is no significant swallowing difficulty, you know? Can you extrapolate like that? Or child has improved, definitely.
Child has improved, sir, because child is now taking normal foods. Started on semi-solid food in 6 months. He can now take normal foods, and he is swallowing difficulty has improved from birth.
Okay. So the very fact that child never had any previous hospitalization for any significant aspiration, or child had a normal nourishment and weight gain. So probably the swallowing problem is probably not that significant now, or it has definitely improved compared.
Swallowing problem has improved, sir. There is no
Improved.
recurrent hospital admission or recurrent.
So the point is the improvement part. So there is definitely some improvement. Okay, it's important to substantiate if there is improvement or worsening. So here there is some improvement. Okay, continue.
Okay.
Right. Babu sir point is very, very important. You need to differentiate improvement or worsening or especially swallowing. One point you said nutrition was perfectly normal. In a case where there is some problem with the swallowing, it will be more of a liquid and the fiber deficiency and micronutrient deficiency is likely in a baby. Here, swallowing is normal. They are giving all sorts of food.
All sorts of, yes, sir. Now the baby is getting all sorts of
fiber and micronutrient. In this case, it's not. Okay.
Okay. Okay, sir. Immunization history, PCV booster is pending. No adverse event following immunization. Family history is a second born of non-consanguineous parentage. No history of recurrent abortion or infant death in the family. No history of any neuromuscular disorders.
Booster only is missing. 10-month, all the doses have taken.
Sir, 9 months PCV booster is pending. Last vaccination was done at.
What we are doing now is to give 10 months vaccine. What are the vaccines given at 10 months now?
Sir, MMR.
MR.
MMR. At 9.
MMR is not there in a national. In the national schedule, there is a third dose of
9 months. It is third dose of fractional
polio.
Booster dose of fractional polio.
Pneumococcal vaccine, MR dose. And now there is, I think, in the JE vaccine also 2 doses.
JE vaccine in endemic area also.
There at the time. You said the pneumococcal only is missing.
Sorry, pneumococcal only missing. JE vaccination is now in endemic areas.
Other vaccines they have taken.
Other vaccines they have taken. Only PCV booster was not taken.
It was not available. Otherwise, it is fine.
Yes, it is not available actually, but it is now. It is not taken until this time.
I think from June onwards, JE vaccine 2 doses are planned. I don't know whether they are getting it.
Other vaccination has taken. Actually, IPV and other vaccine has taken.
Okay.
Nirmal, do you want to elaborate further on the family history? Is it enough?
There is no history of any neuromuscular disorders and recurrent abortions.
Because sometimes these neuromuscular disorders need not be the family history need not be confined to neuromuscular. It can be cardiac. It can be sometimes deafness.
Yes.
Okay. So it can be sometimes premature death. So you have to probably go into the detail. Log surgery for some interstitial obstruction. So especially this myotonic dystrophy and all. You may not be manifesting with just in neuromuscular, or probably you may totally miss the neuromuscular component may not be there also. Okay, so you have to go into more detail, their education status, so many things.
Okay.
So family history, you have to, even though it is, if you are considering a neuromuscular or a neurological issue, need not be confined to just neurological. Other things are also important, especially cardiac, when you are considering conditions like this.
Okay, sir.
Sir was asking about infertility, history of infertility, and so on. Okay.
In 90s, Dasum, myself was in Trivandrum, and there was a family photo of a spastic hereditary spastic paraplegia family for Anandam madam, neurology and the head. Just like that, a family photo need to be examined in this sort of cases because myotonic dystrophy can be there in families with varying expressions and varying problems. Family photo and myotonic dystrophy in the facies you can recognize in another member who doesn't have any of the problems. Only thing infertility മാത്രമായിരിക്കും. അതൊരു clue ആയിരിക്കാം അങ്ങനെ.
Okay, continue, Nirmal.
Okay. Socioeconomic status, he belonged to upper middle class according to modified Kupensamy scale. Coming to summary, it's a 10-month-old male baby born to non-consanguineous parents who is not immunized up to age with no significant family history and antenatal history of polyhydramnios and decreased fetal movements and lower weight, who had a history of an ICU stay which required oxygen support, the history of generalized floppiness, disproportionality, more neck floppiness, and improving gradually with a weak cry initially on OG feeds and later tolerating pallid feeds with global development delay, predominantly motor part.
Another thing you could have mentioned is whether the baby was losing weight initially and now started gain weight. Because child had feeding problem initially. So whether baby was having failure to thrive initially and now started gaining weight well.
And Nirmal, I think the one deficiency in the history is the neurology means history mainly.
Yes,
So at the end of the history, we should be able to spell out, is it a central or is it a peripheral or a combination of both? I think that differentiation is of paramount importance, and you may not get a clue even if you go into physical examination. So you have to have some like concrete idea from the history so that you can go into the physical examination with some anticipation. So once you have summarized this, you tell what are the things you are anticipating, what are things you are going to specifically look for in the physical examination. With this background of history, I have to go by what is known as anticipation. Your physical examination should be a sort of anticipation. So what are the things you are anticipating, or what are the findings you are carefully going to look for in your physical examination? Can you tell it first and then proceed to physical examination?
Sir, hello.
ഞാൻ പറഞ്ഞ കേട്ടില്ലേ? Did you hear?
അവസാനം കേട്ടില്ല sir, last കേട്ടില്ല.
അല്ല, you can proceed. My point is, what are the findings you are anticipating? How you are going to make your physical examination rather a focused examination with anticipation. Generally, we go like that. No? You get an idea from your history. It is more so in a neurology case. Okay.
Can I continue? Hello, sir.
Continue, Normal.
General examination, child was alert, awake, looking around and lying in supine position on the bed with knees and elbows flexed.
ഞാൻ പറഞ്ഞ പോയിന്റ് നിർമ്മലിന് മനസ്സിലായിട്ടില്ല. വാട്ട് ഐ മെന്റ് വാസ്, നമ്മൾ ഫിസിക്കൽ എക്സാമിനേഷനിൽ എന്തൊക്കെ കാര്യങ്ങൾ നമ്മൾ നോക്കും, what are the points you are going to see, or what all things you expect. So there are certain differential possibilities in your mind.
Yes,
so what are the points you are specifically going to look at now? Then that's just a brief preamble for your physical examination, your intentions and your anticipations. Otherwise you can carry തുടർന്ന് പോവാം. Continue. Okay. Continue.
General examination, child was alert, awake, looking around and lying in supine position on bed with knees and elbows flexed. This picture was clicked during baby was active, playful while taking this picture, and while comparing with the normal child of this age, the flexion and activity was little bit reduced. Vitals, heart rate is 128 per minute, pulses were regular in rhythm, normal volume, no specific character, felt equally in all peripheries, capillary refill time less than 2 seconds, respiratory rate was 32 per minute. There is a
poster anything further you want to add?
While comparing with same age, normal babies, the flexion and other tone was little reduced for this baby.
This baby was while child is active.
Child was very active at the time when I clicked this video.
Okay. So the limbs are rather more extended than what you anticipate. in
sir.
a child like this.
Yes.
Okay. And what about the the contours, the body contours? Does it reflect any decreased tone? The hands are open, no, they are not fisting. There is no
Okay.
fisting.
There is no fisting.
There is no obvious contractions you can see at the
Sir.
Sir, point you spend more time on this description of this child because from the impression we got and there starting from antenatal period floppiness like you expected. So is it suggestive of that the commonest of the situation? Child at 10 months, if it was a type 0 of SMA type of situation, it will not be like this.
Yes.
Child is don't see the movement posture of the lower limb. So it's not suggestive of that situation. Child has thrived well. Chest seems to be almost normal. The video should have been much better.
No.
So this is not the thing which you expected from the history so far. Okay, that is a very important thing. As sir was said, telling the open hands. So is there a central element that is important? Is there any dysmorphism? All these things are important from the appearance, and the short video would have been very useful here. Okay.
video undallo, Nirmal, you got video, right?
Respiration time, jerk video, sir.
Respiration undallo, well കാണാൻ പറ്റും. Then other thing is there is no wasting. Obvious ആയിട്ട് wasting നമ്മൾ further ആയിട്ട് നോക്കണം, എന്നാലും വളരെ obvious ആയിട്ട് wasting ഇല്ല.
There is no wasting, sir.
Continue.
Okay. Vitals, heart rate was 128, pulses were regular in them, normal volume, felt equally in all peripheries, capillary refill time was less than 2 seconds, respiratory rate was 32 per minute, the paradoxical respiration present, saturation within normal limit, and BP and temperature also normal limit. Respiration video.
Wait a minute, 1 second. What do you mean by paradoxical respiration?
Paradoxical respiration means this weakness of intercostal muscles and diaphragmatic muscles are intact, so that when we inspire, the chest will go in and the abdomen will come out like see so.
So that is the reason is there is diaphragmatic contraction. Diaphragm is having normal power, and intercostals are weak. Okay. So what are the function of intercostal muscles in respiratory movement?
There are accessory muscles.
Accessory muscles.
Okay, I am not audible. Audible alla?
Audible.
Oh, sir. Allah, that is the movement, chest movement. What are the movement mediated by the intercostal muscles? What do you call that? Bucket handle movement. That is anteroposterior diameter is increasing.
Yes.
Okay, and the diaphragm is a stronger respiratory muscle. So when it flattens, when it contracts, the above downwards diameter increases. Okay, so air is pulled in, but because when the negative pressure is built up in the chest, then the chest wall collapses. The intercostals cannot counter the collapsing pressure of the chest wall. That is the reason. So it may appear as a distress.
Okay.
And but certain neuromuscular conditions can cause diaphragmatic weakness rather than intercostal. Say, for example, in SMA, you expect a diaphragmatic power is normal. You get intercostals weak. Any conditions where you get intercostal muscles like diaphragmatic weakness?
Congenital myotonic.
The congenital muscular dystrophies, I think.
Congenital muscular dystrophy.
Push, sir. Am I right?
Babu.
I think you can look up. That was my impression. Anybody can share. I'm not. But SMA classically there is diaphragm is not affected. Carry on.
Sir, video is there.
At this stage, we need the video because of this point is to be verified. The other thing is the poser need to be verified. The other thing is it a distal or the proximal weakness? Now, if it is a distal weakness present, what are the possibilities? It can be an SMA or muscle disorder.
Muscle disorder.
So that is what is needed. Video play ചെയ്യാൻ പറ്റുമോ? അത്രേ ഉള്ളൂ. ശരിയാണ്. ഡയഫ്രം ആണ് കാണുന്നത് അല്ലെ, ഇന്റർകോസ്റ്റൽ ഇൻവേർഡ് പോകുന്നത്. ശരിയാണ്, ബൈലാറ്ററലി. അപ്പോ സ്റ്റിൽ ഫോട്ടോ വാസ് മിസ്ലീഡിങ്. I thought it was normal, but here it is evident. Intercostal, it's not expanding, but diaphragm is there. And in this case, we could see the elbow flexion, അല്ലേ?
Yes, elbow flexion.
Fingers മൂവ് ചെയ്യുന്നുണ്ടല്ലേ?
Fingers മൂവ് ചെയ്യുന്നുണ്ട് സർ.
കുറച്ചുകൂടി എടുക്കായിരുന്നു ആ വീഡിയോ. വളരെ ഷോർട്ട് ആയിപ്പോയി. Okay.
Definitely there is proximal muscle weakness.
Right.
I know. The baby is lifting the hands above his shoulder also, sir.
That in the vertical position undo, but here as the sir said, definitely proximal weakness, distal sparing and തോന്നുന്നത്. But the possibilities in either SMA or muscular disorders, it will be the pattern. Okay, go ahead.
Anthropometry, weight for age, it's between 15th and 50th centile, and height, length for age also between 15th and 50th centile, and head circumference between 15th and 15th centile. It is all normal, sir. Anthropometric parameters are normal, within normal range only.
Head shape normal ആണോ? Positional plagiocephaly ഉണ്ടോ?
No positional plagiocephaly, sir. Normal head shape and size, no macro or plagiocephaly.
Anterior frontalis closed അല്ലേ?
Anterior frontalis closed ആണ്, sir. Anterior frontalis
closed ആണോ? Open ആണോ?
Closed ആണ്, sir.
Normal, what is the importance of examining the head in this baby?
The shape, sir, if it is a microcephaly, it can be attributed to central cause or with some chromosomal abnormalities or like that.
Macrocephaly ആണെങ്കിലോ?
Microcephaly can be attributed to some inborn error of metabolism.
ഏത് condition you get a large head, you get a hyperacusis. ഈ scenario അല്ല, hyperacusis, macrocephaly, some findings in the eyes.
Central hypotonia.
Central hypotonia.
Degenerative disorder, Nirmal.
Tay-Sachs കണ്ടല്ലേ? GM1 gangliosidosis,
Tay-Sachs disease.
Topic വേറെ ആയതുകൊണ്ടാണ്.
Okay. പിന്നെന്താ നമ്മുടെ ഹെഡില്? What else headile? Natural plagiocephaly, positional plagiocephaly.
Positional plagiocephaly can be there.
What does it show? That is movement കുറവാണ്. That's why.
Okay.
Okay. ഈ കുട്ടിക്ക് it is not there in this child.
Okay. Head appears to be normal shape.
And you may sometimes with pressure there can be hair loss also sometimes.
Alopecia, positional alopecia.
So okay. So that also is not there. Right. So that will tell baby is moving the head reasonably. The weakness is not that much.
Nirmala, in this case, general examination, there is a definite purpose in your examination. First of all, vital signs verification, circulatory status, other thing. Second question you need to answer at this stage, which were not clear from the history, is it a central, is it a peripheral, is it a combination? So that is the most important thing which is served by the video. Okay, so what you are interested is in an SMA-like situation, pure peripheral, in a 10-month-old baby will be enjoying and the bright eyes and the face. That is the thing. It is so striking. A weak child with a very intelligent look. So that is the most thing. If there is a dull look, most important thing, central hypotonia where it is treatable like hypothyroidism. Okay. So if it is a bright or dull and the facies, those are very important. First step, is it a floppy, weak or floppy?
Strong
situation. So central, there all the other parameters of central you need to check. Okay. In the other, if you think it is a bright child peripheral, it can be in the anterior horn cell, in the muscle. So there comes the distribution of the weakness, just like Dasa said, proximal or distal. Okay. And there are certain other points which Dasa, Babu sir will be talking. Okay.
See, what other facial abnormality you will specifically mention?
Okay.
Sir, we look flat facial profile for like
That you have
down.
mentioned already.
No flat facial profile. That's for Down syndrome and all. Then if myopathic facies will be there in case of congenital myotonic dystrophy and all.
So that also you could have mentioned there is no myopathic facies. And also you could have mentioned there is no inverted V-shaped appearance of
there is a tended lip. Is tended lip.
Is it there?
It is there. It is there.
Then you can mention that.
Okay, that's in. I have mentioned the lips, oral cavity and lips.
The facies both ways, dysmorphism or central hypotonia situation. The other one, no dysmorphism, but all these situations of myopathic facies you said, ocular posture you need to say, okay, ptosis and no movement of the eyeball. Okay, all those things are important.
Okay.
Normal. At this juncture, apart from examining the child, you should have examined the mother also. Did you examine the mother?
Yes, mother examined, sir. Mother also there is no dysmorphic issues, or I have looked for all percussion myotonia or grip myotonia.
So that you have to mention.
Okay.
That you have to mention that you looked for percussion myotonia objectively. Okay.
Take hand with the mother, Nirmal.
Sir?
Look at the mother, ask her photograph or family photograph, shake hand with the mother. So don't restrict the examination to the baby, but the mother and the family, including the shake hand, how it is releasing. So very simple things.
Okay, sir.
Especially when she is hauling water from the well, we got history like that. But okay, because they cannot release the grip from the rope to take the bucket. Okay, so such history. So you are specifically asked, it may not be evident, very much evident. Okay, carry on.
Eyes are normal, no hypo or hypotelorism, no upward or downward slants in eyes, no prominent epicanthal folds, no drooping of eyelids. Ears, normal size and shape. Oral cavity, that there's a tending of upper lip present. There is no cleft lip or cleft palate, no tongue fibrillations, no protrusion of tongue. Neck appears normal and chest also normal.
So what is important, you are very likely to be missed is the description of the lips you mentioned. Okay. So what is needed is what happened during the cry and the smile. Because there can be a minimal weakness of the face which may be missed. So what is the thing? 10-month-old baby when happy or dull, there will be some facial movement. Okay. So that is important. Okay.
Especially in myopathies, you have to look for minimal bilateral weakness, facial weakness, which you can miss because there is an asymmetry. Similarly, closure of the eyes, sometimes it may be so subtle that you can miss. Because older children, you can say, close the eyes, screw tight. Then ideally they have to bury the eyelashes. But this baby, you cannot elicit like that. So you have to observe carefully the different moods of the baby, so that whether the facial movements are normal. Okay, so that is important in the assessment. And eyes and facial movements are of crucial importance, whether there is a ptosis, the movements of the eyeball.
Okay.
So SMH, okay. So severe forms of SMA, you find ptosis also, I think. Type 0, sometimes very severe form. Anyway, this is anyway not like that.
Okay.
Okay.
Limbs were normal. Now there is no joint contractures. Skin, there is no neurocutaneous markers. External genitalia, right and left undescended testis. Left testis was at about external ring. It is palpable, and there is no normal volume of testis.
So that finding is very important. The
Yes, sir.
undescended testis, incomplete testis with a normal testis volume for that age.
Very, very important thing. Two things. One thing is always check the testis whether it is descended to scrotum or not. Second thing is the hip Bartolini and Barlow's test. Bartolini and Barlow test.
Barlow's test.
In all case of floppiness, we need to do because there can be unknown, undiagnosed hip this thing in any case of floppiness. The undescended testis can occur in two contexts as a part of malformation. Here it is not so. It is part of the motor unit disorder, especially SMA or myopathy. So both of these are important. Okay.
Moving to systemic examination.
And normal, even it's a small baby, the testicular volume is important.
No, sir.
Okay, so did you mention that the volume?
As normal volume of testis, sir.
Okay.
Okay.
How much is it for a 11-month-old baby?
It is about 2 ml, sir.
Okay.
More than 1.5.
Okay.
Coming to systemic examination, CNS, higher mental function, baby is alert, interested in surroundings, no tonic posturing. Cranial nerves, cranial nerve 1 not tested. 2, eye contact present, fixing and following objects. 3, 4, 6, extraocular movements were normal. No nystagmus, normal.
Normal, just hold it. Just hold it. No.
Okay.
So before proceeding to cranial nerves, higher mental functions, you have to elaborate on that. Because a baby 11 months, whether that baby is able to understand the emotional content of the interaction. That is important.
Baby's alerts are it's interacting with the mother very well.
So that baby is responding to the mother's various expressions, smiling back to her.
Yes.
Okay.
Baby's interested in surroundings and also
show excitement when meeting her. Okay, those things.
Those things are.
So it go into that detail, and similarly recognizing other father or other close people, how baby is reacting, how baby is differentiating them from the other strangers, like that. The baby's excitement. Is the baby excited to see the food? Seeing the food. The subtle things you can elicit. Right from 4 months onwards, the baby may show some excitement on seeing the food.
Okay. Sir.
So these subtle things should be looked at when you are dealing with a condition like this, to know the higher functions.
Okay. Sir.
Okay. Carry on.
3, 4, 6. There's extraocular movements normal, no nystagmus, normal pupillary reflex. Cranial 5, chewing food well. There is no facial asymmetry while crying or drooling of saliva. Able to look towards loud noises with minimal sideward movement of neck. There is no regurgitation of feeds.
There is no need to mention about asymmetry of facial. We don't expect asymmetry.
Yes.
Okay. Partial weakness, it will be otherwise. Okay.
Yes. There is a gag reflex is present. There is no fasciculation. Coming to motor examination, bulk size of both upper and lower limb appears symmetrical. There is no hypertrophy or atrophy seen. Tone on pulling up the child to sit, there is a complete head lag present. And made to sit, it is a rounding of back seen. Head midline for few seconds, then drooping. Vertical suspension, predominantly neck hypotonia. No scissoring seen.
Just one vertical suspension What are your impressions in vertical suspension?
Vertical suspension, actually, baby is not, it is holding in the hand itself, sir. Only predominant neck hypotonia is there. Neck, he can't hold. And there is no scissoring.
Okay, where do you hold the baby? Vertical suspension.
Axilla, sir. Thorax, chest we will not supporting the chest, only the
Okay. So do you think it is just like a normal baby?
not normal, sir. There is the hypotonia, but predominantly neck hypotonia.
Okay. But not slipping through, but it is not normal.
It's not
Okay.
normal. Not slipping
Okay.
through hands.
Okay, what about the hip and knees? What is your impression? I think the baby's feet is touching the bed.
Yes, baby is touching the bed and hips and limbs are normal.
No. What is your idea in eliciting vertical suspension? What about hip and knee? Is there any importance? One is scissoring. Okay, then like central hypotonia versus peripheral hypotonia.
Okay.
Because you have to lift the baby well above the couch.
Yes.
Then only you can elicit whether the child is really flexing the knees and hips in central hypotonia generally. Whereas the peripheral generally it will be hanging loose generally.
In this baby, it is not hanging loose, sir, actually. Yeah, it can flex. It is flexing knee and hip joint.
Okay. Carry on.
Nirmal, two things. Babu sir said, when you are holding for the vertical suspension, in all this case, motor system examination, a little more detail. You describe about the attitude and posture. Second thing about the bulk. Third thing is of the distribution of the power and the weakness part. Where is moving, where is not moving. Okay. Then this thing, flipping to 180 degrees. The first part, pull to sit you are demonstrating with the head lag. After that, then the vertical suspension. In the vertical suspension, it's not tightly holding the chest. Just hold the chest and pull and see whether it is slipping through the hands or just holding. And that is important. And you lift the baby off the table first and see two signs. One is the flexion at the hip. Is it there or totally hanging? The second thing is there any scissoring. DeLange sign and what is the other sign, Babu? There are two signs at the hip. Okay. Babu, muted. You are muted.
Crochet sign and തോന്നുന്നു എനിക്ക് ഷുവർ അല്ല എന്തോ crochet
One is the hip flexion.
Foster.
That side.
എന്താ മോന്തസെ മറന്നുപോയി ഫോർസ്റ്റർ എന്തോ സാധനം എന്തോ ഒരു സൈൻ ഉണ്ട് അത്
and DeLange sign. Okay, that will be demonstrated only if you lift
baby
totally off. And after that demonstration, you bring back to the table and see the posture of which part is touching. Okay. In the floppy situation, toes will be touching and followed by the heel also will be touching. If it is a spasticity, also the toes will be touching, but bone coming down, heel will be above. So spasticity and floppiness, both the situation, toes will be touching, but floppiness, the entire foot will be touching the table because it is totally weak. The other situation, it is just a toe walking. Heel will be remaining above and some scissoring also. So central and peripheral type of weakness, the attitude and posture and flipping through 180 degree is to be done. Okay. In this case, one very important finding you see, there was total lag in the pull to sit. Here, there is not much of down. It is a little bit of power in the extensors, power or tone in the extensors. Hello, Babu?
Yes, sir. It's momentarily holding, sir. It is, sir.
It's not what you
momentary
expect. Weakness ഉണ്ട്.
It's only momentarily holding, sir.
Corresponds to 4 weeks ആണുള്ളത് momentarily line of the body.
Here again, the way you are holding in this position is at the tummy.
Yes.
rather than, okay, here you're holding mostly on the shoulders
chest.
and the chest you are supporting. Actually,
Yes.
it's not the way.
Hmm.
Okay. Then only you will see the inverted U posture if you are supporting at the tummy part.
Okay, sir.
Totally floppiness, you will get the inverted U. Just like you're holding a snake on a എന്താ പറയാ വടീന്റെ മുകളിൽ ഒരു പാമ്പിനെ വെക്കാൻ ഇൻവേർട്ടഡ് യു ആയി മാറും. സോ ആ ടമ്മീന്റെ മുകളാണ് സപ്പോർട്ട് ചെയ്യേണ്ടത്. ഓക്കെ.
Okay, sir. Okay, sir. Coming to the power, the best observed power in the upper and lower limb, it is 3/5 for both right and left side. Palmar grasp is present, but it's weak.
It's not enough. ഇവിടെ പറയുന്നിടത്ത് ദാസ് നേരത്തെ തന്നെ ചൂണ്ടിക്കാണിച്ചല്ലോ. Is there a proximal or distal weakness? Okay. In SMA and muscle disorders, proximal will be lower grade and distal will be. So that is the hallmark in any case. Okay. So otherwise, it will be central weakness. Central weakness, everything will be same. In a peripheral weakness, there will be disparity between the proximal distal. In a central weakness, it will not be there.
Okay.
Sir, impression about the peripheral like distal versus proximal, your assessment?
Sir, there is no much difference. I cannot differentiate actually.
Normally, your voice is breaking.
Actually, on my examination, there was no differentiating from proximal, whether proximal is more affected or distal. It is equal, I think, sir.
How do you check it, the distal power?
Distal power, child is holding to the objects. He can hold to the things, and palmar grasp is present. And proximally, he is lifting the hand above the shoulder. And
there is no wasting. There is no wasting.
No wasting.
No contractures, and the
no
baby is transferring objects. The grasp of the baby. What is the grasp?
Grasp is sir, but it is weak. He can hold on to toys, but it is weak. But not transferring the things from one hand to another.
Is the child transferring object to one hand to other?
No. Child is not transferring object to one hand to other.
Child can hold or it falls off.
It can hold. It can hold. Sorry, child can hold. He's holding on to toys and all things and introduced toys.
Okay. So that part is not very clear. Proximal versus distal. That part is not. Okay.
Coming to reflexes, only ankle jerk was elicited. Other all deep tendon reflexes were absent. Biceps were absent. Triceps, supinated knee all are absent. Ankle jerk were elicited. And plantar reflex, bilateral flexor response only 80. Ankle reflex only present.
Here you can see child is actively moving the feet.
Yes, sir.
Okay. You could have tried to restrict the movement of the feet so that you will know how much the distal power is.
Oh.
The toes, how the baby is moving. I think it is not easy for a baby to assess subtle changes. So you have to ingeniously elicit.
Okay.
While you are in fact eliciting other signs like a tone or reflexes, you should have a concurrent assessment of the power also, like proximal versus distal and all. Okay, there is definitely the ankle jerks are elicitable.
Okay, ankle jerks only elicitable.
Elicitable.
Neonatal reflexes, sir.
And also it is important to assess the degree of reflex and the muscle power. Is there a discrepancy or it is proportionate to the power, muscle power, or it is reflex is decreased? What is your impression?
It is not proportionate, sir. Muscle power, it is best observed power is 3/5 in all right and left arm. So angle jerk is only we only are eliciting angle jerks. Other all biceps, triceps, supinator, and knee jerk were absent.
See, while you are eliciting the reflex, is the child moving against your
Yes,
when you restrain, when the child is moving against with force, so it is
Yes,
not just 3, it is slightly above 3, right? Is it
Yes,
like
sir.
that?
Yes,
What is
sir.
your impression?
Yes, sir. Child is
Okay.
moving against the
Some
resistance.
resistance. Okay, not over and above the gravity.
Yes, sir.
But reflex you are not able to elicit apart from the angle jerk.
Angle jerk only.
Generally, when you elicit reflexes like knee jerk, bicep jerk, supinator, angle jerk, which reflexes you get better in the gradation? The
Sir,
classical teaching is knee jerk is naturally brisk. Okay. When you are getting angle jerk like a knee jerk, that is to be exaggerated, right? So here you are getting angle jerk, but you are not getting knee jerk.
knee jerk. Okay, sir. Plantar is bilateral flexor response. Sir, can I continue?
Babu, you are muted, Babu. Muted, Babu.
Okay. The plantar response again, it is a very difficult task to elicit in a baby like this. Are you very confident it is bilaterally flexor?
Yes, sir. When I elicit, I got bilateral flexor response. But up to 1 year, bilateral extensor response can be seen in infants normally.
Okay. Okay. Okay, carry on.
So that point, of course, is questionable. The plantar flexor, no? Of
Yes.
course, that inward, no? Development of child. Here they have done, no? He has mentioned the extensive study has been done in neonates and this thing. But still, textbooks mention that plantar can be extensor. If no other problems are there, extensor plantar can be considered as okay. But if there is a neurological problem and this thing, that cannot be taken as the usual normal. This
Okay,
is
very
there.
true. Yeah. Very true. So it is there in Illingworth, very clearly.
Yeah. Thank you.
Yeah. Okay. Thank you. Normal proceed.
The neonatal reflexes were not elicitable. More routing, stepping, asymmetric tonic knee reflex could not be elicited. On
What is the reflex which you can, the primitive reflex you can elicit at this age?
Postural reflex, parachute reflex.
Did you try that?
No, sir. The neck, the neck has predominant neck is child is not holding the neck properly.
Okay.
So that I cannot elicit that.
Okay.
Nirmal,
Sir.
One thing you miss in the motor system is after you do the pull to sit, vertical suspension, pendular suspension, pound position, 180-degree flipping, you need to assess the amylase angles also. In any case of hypotonia, in this age group, they'll be asking about the amylase angles. Those should be mentioned. Okay. And rightly pointed out by Babu sir, very difficult to document the reflexes in such a young child. You should be very patient. Very likely that in this case, your interpretation of the determinant reflex is wrong. Because that combination is very unusual. Angle jerk present, the other jerk absent. It's very, very unlikely. So that is a problem. Most likely you have missed it. You need to reassess it in a very calm situation. You should be patient before you put your the jerk elicitation in a very young child is difficult, especially in these days. Okay, and that is so important also because you have some points which are very relevant. Like you are considering SMA. In that situation, it will never be possible. SMA reflex are very, very unlikely, but the other possibilities, other conditions, it may be possible. So differentiation is very, very important. There are points for and against it. So reflex are one of the arguing points. Okay.
Okay, sir. Coming to sensory system, child is able to perceive touch and pain, reacts to cold temperature by crying. Cerebellar sense, there is no nystagmus, spine normal, cranium normal. There is no joint contractures or callosities. Coming to other system examination, cardiovascular system, it is no murmur, no gallop. It is within normal limit only, cardiovascular system. And respiratory system, shape of
One
chest is
point,
normal.
you go back to the previous. Where is the apex you mentioned here? Next slide. Where is the apex? You're going into trouble in the examination because in the fifth space, it's in this case, it's so important.
Yes, yes.
In this case, it's so important because 2 point in this case is a Pombe's disease, where in the general examination, we miss the tongue. Okay. Tongue is important in the general examination, which indicates a storage. The other thing is the presence of the cardiomegaly and the sounds. Murmur is less important. Most important is the position of the apex and the heart sounds. Okay. So don't expect any murmur or anything. So position you mentioned in the fifth space in a 10-month-old child means you're arguing totally for a different thing. Okay.
Okay, sir.
The presence of the liver and the liver span also is important.
Okay.
In this case, you check the apex. Okay.
Okay. Respiratory system, there is a paradoxical chest movement of chest wall going in and abdomen moving out during inspiration. No other positive findings was there. Abdomen, on palpation, abdomen was soft in consistency, bowel sounds were present, and there was no organomegaly. Coming to summary, it's a 10-month-old male born to non-consanguineous parents who is not immunized up to age and with no significant family history and significant antenatal history of polyhydramnios, decreased fetal movements and low birth weight, who had history of NVS stay which required oxygen support, with history of generalized floppiness, disproportionately more neck floppiness, and which improved gradually with a weak cry and sucking difficulty, with global development delay, predominantly gross motor domain. Examination revealed tending of upper lip, bilateral undescended tested with hypotonia, predominantly involving neck with intact sensorium. It can be floppy, weak with intercostal weakness along with a sluggish reflex only in the angle. And other systemic examination were within normal limits.
ദാസേ നമുക്കൊരു 15 minutes കൂടി എടുത്തൂടെ ദാസേ?
Okay, okay.
It can be a floppy infant with hypotonia predominantly involving neck, probably a peripheral cause.
Yeah, are you sure there is no central element in this?
Most probably, sir, it's a peripheral cause.
So the thing is, there are certain lacunae in our examination to definitely say that the higher functions like cognitive skills of the baby, everything is perfectly normal. Or you have to postulate that baby had some issue in the newborn period, probably some hypoxic injury would have happened. So that would explain some central element to this. But you are not able to substantiate that is perfectly normal. Yes. Right? So the predominantly it is a peripheral. Okay. Very good. So this, even if there is secondary like central, it likely to be some secondary, if at all it is there. So that part is not very clear in the, we could not really elicit. Okay, of course there is a limitation in eliciting these signs. That is agreed. So your first
mechanic syndrome in this as a differential diagnosis. The last one, is it acceptable?
No. Congenital myasthenia is less chance. There is no ocular manifestation in our examination.
I think we can avoid that. Yeah.
Okay, sir.
last and chromosomal abnormalities also, I think, less likely. Okay.
Less likely.
Nowadays, any chromosome to study something will be positive. So better, that is okay, I think.
I think you can keep Prader-Willi syndrome as well.
Prader-Willi, okay, right. That was what I was. Because Prader-Willi, sometimes the other features will be taking some more time later. 2 years onwards, the obesity and the eating can occur in a place of Prader-Willi. If at all you are keeping congenital chromosomal problem, Prader-Willi is one possibility. Still, I think by this time some pigmentation, fairness, fair complexion, all those things will be evident by this time.
Some of them itself can be chromosome. So, but even myopathies can be sometimes chromosomal. Nowadays, if you do genetic studies, you will find something positive.
Yes, of course. All those things, there is a genetic basis. Okay. In a Prader-Willi, by this time, you will be getting some eye abnormality and fairness. And a little later only, the feeding and obesity will start. That is the sequence of events, I think. That's anganyano?
I think important thing is eyes for, I think, Prader-Willi. So I think he has to specifically mention regarding the finding in the eye. And probably even earlier feeding difficulty, later picking up. And so Prader-Willi is, say, for a discussion, I think that possibility can be entertained as a possibility for discussion's sake, though it is a remote thing only, because there are no other thing to say.
Another thing is, apart from spinal muscular atrophy, conditions like congenital myopathy, myotonic dystrophy, congenital muscular dystrophy, all these can have some central element also. They will lag in other fields of development also.
Okay, all this except apart from unlike in SMA, like as you said, muscular dystrophies, congenital muscular dystrophies, various, like not only just muscle brain eye, many of the congenital dystrophies, myopathies can have central involvement also as such. It's being a developmental thing, genetically mediated, you can have associated things also. But characteristically, cardiac involvement is not there, eye involvement is not there. These two things are characters, and no hepatomegaly and all. So these three things are ruling out many of the other conditions. There is no eye like extraocular or notosis, nothing.
Is it a static problem, progressive problem, or so? Will you address that?
It is a very, very important as far as parents are concerned, and the prognostication and genetic, because for the parents, they want to hear a positive thing. And for us also, child is thriving comparatively now, almost normal situation. A little bit of floppiness is there. Otherwise, okay. So in case it happens to be some of the good prognostic myopathies, few of the myopathies are having a good prognosis, not all the ones. So good prognostic situation of a myopathy is a desirable thing. So we need to go for a firm diagnosis of genetic situation also. In the last part, Srinivas sir pointed out myasthenia and congenital myasthenic syndrome. The point against is majority of them prefer the eye, face, and the swallowing part. By the time you get the weakness of the limb, this cannot be spared. So in few of the congenital myasthenia syndrome, I heard salbutamol will be working. I don't know which one among them. Salbutamol. You may not be aware of this thing. Few of the which condition I don't know. There are a variety of these congenital myasthenic syndromes. Some of them, the salbutamol will be working.
Many of the some channelopathies, they respond to salbutamol. Not only this, including cardiac thing, certain channelopathies, they respond to salbutamol. I think even Burgado syndrome has got some thing. I think there is.
Okay, go to the investigation, I think.
Clinically, I think you can rule out SMA because it is not a progressive problem. and you are getting ankle jerk, elicitable ankle jerk. Very unlikely that usually neuropathy's ankle jerk is the first thing to lost.
And another thing is there is the origin is the onset is in utero. So if it were a SMA, by the time 11 months, you would have seen deterioration, not like this picture. But it started in utero. That is for definite. There is undecided testis, there is hydramnios, there is decreased fetal movements. So there is the whole possibility of congenital myopathy more likely, and it can explain some central involvement also, maybe depending upon the genetic abnormality. I think that may be the more tangible this thing in this case. SMA is, I think, straight away.
There is no myopathic patients.
Very important point. The boldness of the mentor and Nirmal, not to mention about SMA. Any other candidate presenting would have been at least second possibility they would have put the SMA. So they are bold enough to totally avoid that. That is a very commendable thing, because definitely, as Mohandas pointed out, considering all the possibilities, starting in the in utero period, now surviving, and the ankle jerk. So it is almost 100% you can say you need not be thinking about that. It's very unlikely. That is not the cause of the SMA. So it must be something else. Among the something else, what actually? It can be a myopathy, it can be other possibilities also. The ruling out boldly of the SMA from the list is commendable.
Shruti did not talk. Shruti.
Shruti ഒന്നും പറഞ്ഞില്ലല്ലേ?
Shruti, would you like to add to this discussion? Shruti poyo.
No.
Sorry, sir, I'm losing my Wi-Fi connection. Sorry.
Oh, I see.
Investigation എന്തായി? എന്തെങ്കിലും ചെയ്തോ? CPK?
Sorry, sir, I missed in between. So,
Sir, actually, I went to this patient's home and took the history. They had the investigation they had is MRI they took, and it was
Actually,
normal.
that is the waste of thing. ആവശ്യമില്ലാത്തൊരു കാര്യമായി പോയി. When you're presenting, when you're thinking, ഇതിപ്പോ GP style ആയി പോകുന്നു. When you're talking discussion, academic discussion and all, you're going for the MRI. That is the last investigation needed in this, and the money should be bought from the this കൊടുക്കണം അവർക്ക്. അതാ പറയാ, MRI ആദ്യം ചെയ്യിപ്പിച്ചിട്ടുണ്ടെങ്കിൽ. അത് നമ്മളിപ്പോ ഈ ഫോറത്തിൽ പറയുന്നത് ശരിയാണെന്ന് അറിയില്ല. ഇൻവെസ്റ്റിഗേഷൻ വുഡ് ബി ഒരു സീക്വൻഷ്യൽ ആയിട്ട് വരണം. വേണ്ടത് ആദ്യം പറഞ്ഞിട്ട്
other investigations are done, അല്ലേ? You can mention.
Other investigation, karyotyping was done.
കാരിയോടൈപ്പിംഗ് അല്ല ആദ്യം വരേണ്ടത്. ആദ്യത്തെ പറഞ്ഞിട്ട് സീക്വൻഷ്യലി പറ.
Actually,
first you tell about CPK.
നമ്മളെ CK അല്ലേ ആദ്യം പറയാ.
അതെ, but those
കുഴപ്പമാണതല്ലേ?
അല്ല sir, those reports were not available. That's why actually investigation only this investigation I could collect from them. That's why
So CPK
CPK was the reports was not with them.
Okay,
that's why.
Okay.
Then DNA based testing for mutation analysis.
Dharma, it was worked up from elsewhere. പല സ്ഥലത്തും worked up ആണ് അല്ലേ? That case.
Initially workouted from where else? Then only review we saw this patient. And
among the ladies, in which condition you get some finding in MRI?
MRI usually in central cause congenital myotonic dystrophy. No. Congenital myotonic dystrophy, it can be both, sometimes both central and peripheral.
Congenital muscular dystrophy,
muscular
you
dystrophy.
can get some findings, especially in myrosin deficient congenital muscular dystrophy. You can get a very characteristic MRI finding.
In leak syndrome, mitochondrial disorders, sometimes leak syndrome പ്രത്യേകിച്ചും അതിൻ്റെ അകത്ത് കോസിൻ്റെ അകത്ത് swallowing difficulty will be more.
And ocular involvement ഇതിന് തീരെ ഇല്ല. That is characteristically.
It's not suggestive, but the MRI is diagnostic, especially this MR spectrometry. Other leak syndrome in the mitochondrial helpful. In this case, CPK is the most important first line investigation. That's why നമ്മൾ കമന്റ് ചെയ്ത് ഡോക്ടർമാരെ കമന്റ് ചെയ്യല്ല. എനിവേ നമ്മൾ പ്രസന്റ് ചെയ്യുമ്പോൾ ഷുഡ് ബി പ്രസന്റിങ് ഫസ്റ്റ് lab investigation followed by in a sequential thing costly and invasive last. Simple investigation first. So what is needed first is the CPK.
CPK.
Transaminase. Okay.
Then we have go for DNA based testing, electrodiagnosis, EMG and NCS, then to muscle biopsy and nerve biopsy. In this,
now that almost the molecular diagnosis has replaced EMG and muscle biopsy and
NSS. Yes.
The diagnosis, molecular diagnosis.
Sir, for this baby karyotyping was native and gene expansion for myotonic dystrophy also was normal. And in whole genome exome sequencing, a variant of uncertain significance like axonal Charcot-Marie-Tooth disease type 2O and lower extremity predominant spinal muscular atrophy 1, which is of variant of uncertain significance, sir. Only that we got in all genome.
The point I actually wanted to mention is when you are examining nervous system, you should not mention that it's the central nervous system. It is nervous system, and you should have examined for the peripheral nerves also. In peripheral nerve thickening, especially this sort of conditions, you will get thickened peripheral nerves. Very unlikely to manifest at this early. Still, some varieties can manifest early.
ഈ ഏജിൽ ഉണ്ടാവോ മന്ദാസ് ഈ Charcot-Marie-Tooth പോലെയുള്ള സാധനങ്ങൾ?
Usually we see during later part of infancy, around 7-8 years and all, we will see some cases, but I don't know. But you have to, whenever you see a floppy child or a peripheral weakness, always palpate the peripheral nerves also.
Yes, sir.
That will be the diagnostic finding you will get.
SMA molecular test ഏതാണ് വേണ്ടതെന്ന് പറഞ്ഞില്ലേ ദാസേ? whole exome ആണോ അതോ?
No. SMA you won't get in whole exome or medical exome. You have to do the MLPA.
MLPA ആണ് അല്ലേ? MLPA തന്നെ.
MLPA negative, you can go for exome. A small percentage can be due to point mutations, but large majority is due to deletions, and so that will be picked up in MLPA or multiplex PCR.
അത് റയർ ആയിട്ടല്ലേ മൾട്ടിപ്പിൾ PCR നമ്മളെ SMA2-ലൊക്കെ?
അതെ. Now
അപ്പൊ Mandas, anything to add from your genetic diagnosis point of view? How to proceed?
So here it is a neuropathy is less likely because of the preserved ankle jerk and other jerks are lost. We have to carefully examine for other reflexes, as Purushothaman sir mentioned, whether that finding is correct or not.
വളരെ നോക്കി, പക്ഷെ എന്താ വെച്ചാല് എലിസിറ്റബിൾ അല്ല. When you bicep jerk is just elicitable when you the tendon is directly elicited on the tendon, bicep tendon. Without you cannot keep your thumb and elicit straight away on the tendon. Then you get flicker of contraction. Whereas ankle jerk, with difficulty, it is like as demonstrated can be elicited. But knee jerk, all the different positions we could not. Probably the flicker of contraction you are not able to see because of the flabby.
Probably the finding will be correct because in most of the videos, predominant proximal weakness is more evident than the distal weakness. So probably the preserved distal reflex also may be the correct finding.
But a child is lifting the hip again with some force. We are not able to elicit a knee jerk because child is voluntarily lifting. So characteristically, it disproportionately diminished reflex compared to the power. Or so it's not a very straightforward, but the more likely is a congenital myopathy rather than
the facies is not abnormal. You expect an abnormal facies in congenital myopathy.
Myopathy, okay. Yeah, that's right.
Congenital myotonic dystrophy, probably he mentioned there is tended lips and all.
പക്ഷെ അത് നമ്മുടെ ജനറ്റിക് ടെസ്റ്റ് നെഗറ്റീവ് ആയിരുന്നു.
Already
അത് ക്ലിനിക്കൽ
testing done and it
പോസിബിലിറ്റി
is ruled out.
റൂൾഡ് ഔട്ട്.
So we will have to consider this whatever diagnosis came up from this molecular testing. Careful palpation of the peripheral nerves will help. And when you get this variant of unknown significance, you can check the unaffected members of the family also for the same mutation. And
പാരന്റ്സിനെ നോക്കല്ലേ?
parents, and if they don't have that mutation and child only is having that, probably you can consider this diagnosis.
One 11-year-old boy is there alive, അല്ലേ?
അതിന് കുഴപ്പമില്ല.
അല്ല, they are already 39 years അല്ലേ mothers, അതുകൊണ്ടാണ് we cannot take risk. We need to follow up this baby for another 1.5 years അല്ലേ അപ്പോൾ അറിയുള്ളൂ. ഞാൻ എൻ്റെ ഒരു കമന്റ് about the doctor, I withdraw. My comment was always investigation should be stepwise, simple investigation first. Okay, maybe the MRI was taken at the end of this thing. പെർസെന്റ് ചെയ്തതിന്റെ ഒക്കെ ആദ്യം MRI ചെയ്തു എന്നുള്ള ഇംപ്രഷനിലാണ് ഞാൻ കമന്റ് പറഞ്ഞത്.
അതല്ല, അത് പഴയത്. ആക്ച്വലി ഹി ഓൺലി പുട്ട് ഇറ്റ് ഫസ്റ്റ്. അതല്ല, ശരിക്കും അത് പല സ്ഥലത്തും ചെയ്തോണ്ട് ഹി ഗാതേർഡ് ഓൾ ദി തിങ്. I don't know why Nirmal put MRI first. എന്താണെങ്കിലും കുഴപ്പമില്ല. So he gathered all the previous records.
Tell these things systematically. Based on the differential diagnosis you have, you can put forward the investigations.
അങ്ങനെ പറയണം. നമുക്ക്
വൈൻഡ് അപ്പ് ചെയ്യാം അല്ലേ?
നല്ല കേസായിരുന്നു കേട്ടോ.
Thank you so much.
Sushma madam, Parvati madam, anyone here?
Thank you so much കേട്ടോ എല്ലാവരും.
ശ്രീനിവാസ് സാർ ഉണ്ടോ?
ശ്രീനിവാസ് സാർ, you left? Sir?
പോവില്ല, സാർ ഉണ്ടാവും.
Sir ഉണ്ടാവും. Okay.
Thank you so much. Nice to see Babu.
പാർവതി
madam.
ശ്രീനിവാസ് സാർ അവിടെ ഉണ്ട്.
ഉണ്ടല്ലേ? ഏതായാലും താങ്ക് യു പുരുഷോത്തമൻ സാർ.
Sir, you are muted.
Mohandas.
Sir, you are muted. Srinivasan sir.
Sir, you are muted, sir. Sir, കേൾക്കണില്ല.
Nice to see Babu Francis. കുറെ കാലമായി കണ്ടിട്ട്.
It's a very interesting
Nice
case.
seeing you, madam.
Of course,
Yes,
very
sir.
definitely one cannot say anything, but it's nice, well discussed. Yeah. Thank you.
Thank you, sir. Thank you so much for your valuable inputs. Mohandas, Pushu, sir. Nalle, thank you for the valuable inputs. Thank you for giving me this opportunity. നിങ്ങളോട് ഡിസ്കസ് ചെയ്യാൻ പറ്റിയതില്. Thank you, Nirmal. നിർമ്മല കുറെ he put in lot of effort. വീട്ടിൽ പോയി അവരുടെ പഴയ ഡീറ്റെയിൽസ് ഒക്കെ എടുത്തു. വളരെ വളരെ സിൻസിയർ ആയിട്ട് വളരെ മെനക്കെട്ട് കാര്യങ്ങളൊക്കെ ചെയ്തു. പല പ്രാവശ്യം എക്സാമിൻ ചെയ്തു. Okay, Shruti helped him so much. So thank you.
And let us know the follow-up of this case also later. Discussion
very important.
Stopping we need a follow-up of all these cases in the coming months. Okay.
Sure sir. Thank you.
Good night.
On behalf of IAP Kozhikode, I would like to congratulate Dr. Nirmal Raj and his mentor, Dr. Shruti, for the wonderful case presentation. Dr. Babu Francis sir, who led the discussion, which was very fruitful, and other senior faculty members who attended, including Professor Srinivasan and Purushottam sir, Parvati ma'am, for adding on to the case discussion. And I'm sure that not just the postgraduates, but all of us learned a lot from today's discussion. We would like to thank IAP Kerala for the opportunity to host this program. And thank you everyone for attending the program. Thank you.
I have to thank all of you for giving me this opportunity to learn from these cases.
It's a blessing for us.
Yes, sir.
Actually, your presence is a blessing for us.
Others. Thank you all. Good night. Bye, sir.
Good night.
Good night, all of you.
Good night.
Good night.